Thank you so much for joining me in this session today, Dr. Sandesh. And I'm like so happy to have you over.
Uh, I'm actually honored to be invited on this stage. Thank you so much for the invitation. Yeah.
So before we start the session, let me just give you a brief introduction of Dr. Sandesh and what he has done. So Dr. Sandesh has been a pioneer, when it comes to gynec laparoscopic surgery, with over 22 years of experience in India and abroad, with expertise in minimally invasive laparoscopic and endometriosis surgeries, along with pelvic floor repair surgeries. He is serving as the managing director of Sunrise Hospital at Solapur, India, and has been associated with a number of hospitals in India and abroad as a gynec surgeon, performing over 10,000 surgeries. His areas of expertise include fertility-enhancing surgeries, minimally invasive surgery for pelvic floor repair, laparoscopy for large fibroids and multiple fibroids, complex keyhole hysterectomy, moderate to severe endometriosis, and hysteroscopy for septum, polyp, fibroid, adhesions, and corneal block. So Dr. Sandesh has trained over 200 gynacs and conducted several workshops for laparoscopic surgeries across India and abroad. He has represented various national and international courses as the faculty. He is also trained in neuropelviology and neuroprosthesis in gynac specialty. For basic understanding of what neuropelviology is, it's a new specialty in medicine that includes the diagnosis and treatment of pathologies and dysfunctions of the pelvic nerves. So welcome, Dr. Sandesh. This is
Thank you so much
an amazing bio that you have, and a lot of people would get a lot of knowledge from this particular session that's happening today. I'm sure of that.
Thank you so much. Yeah.
So you have been practicing for so many years. So the first thing that I want to ask you is, what is the main symptom that patients come to you with before you diagnose them with endometriosis?
Okay. As you know, this disease affects 5 to 10% of the women between 15 to 50 years. So a big chunk of the patients coming to me is adolescent age girls who come with main complaint is pain. So basically it is pain which is around their menstrual cycles. So it could be just before or after the cycles, and it is very, very severe. And this is actually they come or seek treatment or opinion is because they are actually suffering from it. They are missing their school, or they have to take medications. Some are even have to reach emergencies like every month, and they have to take injectables. So the basic symptom they come to me or present to me is for the pelvic pain, especially during menses. That is we call in medical terms the dysmenorrhea. So that is the main feature they come to me. And the other patients who come to me in reproductive age group are for infertility. And the patients then are referred directly with some ultrasound report. This is how the patient profile is, what I see in my daily clinic.
Amazing. That is great. So now, pelvic pain is something which most of us know is one of the common symptoms of endometriosis. But I believe there are a lot of other symptoms associated with endometriosis. So besides pelvic pain, are there any predominant symptoms of endo?
Yeah, see now endo, it is considered like to be a gynecological disease, but it is not so. It's a full body disease. So the although the pain or the disease starts in the pelvis, but it can affect the organs around and distant to pelvis. So the most common presentation could be the affection of the peritoneum lined in the abdominal cavity. So majority of these women or girls, they come with pain and nobody understands what exactly is causing that. Now if it goes to the bowel or the rectum, colon, appendix or small bowel, then they represent with the bowel symptoms. So especially they have the bloating or they have constipation alternating with even diarrhea. So they come with severe abdominal cramps and pain during bowel movements. And some are even afraid, even like with that thought of passing stools that it's so painful for them. They are almost into subocclusion. So, and very often I have patients or the emergency referrals for obstruction, and these are the patients with severe form of bowel endometriosis. Now, if it affects the urinary tract, then they come with pain during urination, dysuria, or if it's the ureters, the pipe which carries urine from kidneys to the bladder, if it gets affected, then on that respective side, they have pain in the flanks or the lower back, and that could be even affecting their kidneys. Now, not only related to the pelvis, but this disease can even go higher up into the upper abdomen and can settle at the diaphragm. So there they would have pain, or there like every monthly they could have some bouts. If it affects the lungs, they could even have blood in their cuff. So depending on which organ is involved. Now, a lot of them can have still deep infiltrating. 5 to 10% of the patients have the deep infiltrating type of endometriosis, and so it can go very deep into the lower part of the pelvis or even the outlets of the pelvis, where a lot of nerves can get affected. So depending on which organ is involved, there could be many features, and these patients are actually tired. They have fatigue, they have fainting attacks, and they are really incapacitated by this disease, and it affects their quality of life. So it could be a multifaceted presentation, is just mix of a lot of features, and but overall it is a struggle, and mainly there it's a suffering. That's how they can present to us.
Absolutely. So I had a severe bowel endometriosis and I had a block in the intestine. Also there was another major symptom that I had for a very long time was leg pains.
Mm.
Okay, so I wanted to check how, I mean, is leg pain associated with endometriosis and how common is it if it is there?
Yeah, this is a very good question, because see, mostly people feel if she has some leg pain, then it has to do something with the bones or the muscles of the leg itself, or there could be like the spine problems. You know, so these main problem with endometriosis is the overlapping symptoms. So these patients usually land up with the orthopedicians, or they even go to like they can have leg pain, so they go for a Doppler, thinking that there is some vascular problems. But very often, leg pain is a presentation for endometriosis, and it is because actually the nerves which are going out of the pelvis from the sacrum into the leg, they are affected, and depending upon the right or the left side, whichever affected, the patient presents with leg pain as a very common feature, and especially that could be radiating to the back, buttocks, and in the extending into her thighs and into the calf muscles, or very often in the anterior part of the thigh, depending on which nerve is involved. So yes, leg pain could be a feature of or a symptom of endometriosis.
So I remember every time I went to the doctor, all that the doctor had to say is increase your muscle strength, increase your calcium, increase your walking, start exercising a little more. The strength is a little lesser. Go for a physiotherapy. That's what I kept doing all the time. And I remember after my excision surgery, after my surgery that I went for my endometriosis, I had like severe pain in my upper thigh, and that was one of the major symptoms that I had. And the doctor had told me at that point in time that you had lesions near the nerve endings, because of which it was there. That's when I realized that, okay, leg pain was because of the endometriosis and not because of anything else.
Okay.
So I think a lot of other people have been getting dismissed because of it, because there is a group that we have, and there are a lot of it's basically a women's group. So there are a lot of women saying that they have leg pains, they have back pains, but again, no one has ever told them that this is one of the symptoms of endometriosis. So thank you, Dr. Sandesh. This was like really helpful. So now shifting to the next part, nerve involvement is again something which is very common when it comes to endometriosis.
Okay.
So if your nerve is involved in endometriotic lesion, then what can be done in such a situation?
See, if you see the pelvis, the nerves are not seen when a surgeon performs the surgeries. The nerves are very, very deep inside. So basically, that's why we say God is the best architect, and because the nerves have to be preserved. So they are very deep inside the pelvis. And they are actually what we call the powerhouse of everybody, like they from where the energy is generated. So they are protected by nature, but sometimes this disease can find its way, or it can just evolve in that part, that it's not at all seen in the laparoscopy in the peritoneum, but it could just de novo arise in over the nerves, or the areas which are around the nerves, and it can compress or even damage those nerves. So depending on which nerve is involved, the patient presents to us. So very often the commonest nerve involved in endometriosis is the sciatic nerve. So basically sciatic nerve is formed, it's the biggest very thick nerve, and it is formed by joining of many nerves, the nerves arising from the lumbar area or the sacrum, and these nerves, they join together and they form a sciatic nerve. So depending on if the endometriosis is affecting the upper part, then that part of only of the nerve ending will be affected. So it could be the sciatic nerve could be involved. There is another big nerve which is formed, is called as the pudendal nerve. So this nerve would go to the perineal area, that is the around the urinary system, or it can go around the perianal area, so around the bowel symptom area. So depending on which part of that nerve is involved, the patient is actually telling us that I have pain only during urine, passing urine, or during the rectal pain. So in that particular history, we really have to think that what is she really suffering from, or what is she really trying to tell me. So yes, the nerves commonly involved sciatic, pudendal, or obturator, or there is another nerve which is called as the genitofemoral or the femoral nerve. So if the patient has very extensive disease, she can even have trouble walking, or especially there could be problem only with steps. So depending, we really have to go ahead and allow her to speak. Actually, that's my first theory is let the patient speak her heart out, and then we'll actually come to the diagnosis.
Absolutely. So the key is listen to your patients.
True, true.
That's the key. So when it comes to any diagnosis, listening to your patients actually leads to your diagnosis in a much better way than just dismissing them, or just relying on a particular radiography or imaging for that matter. A lot of times patients give you the right exact symptoms because they are going through it, right?
They take you to the diagnosis, only unfortunately we interrupt them and then we are lost.
So, it's not easy to deal with endometriosis, even before surgery or after surgery. So how important is counseling for a patient pre and post surgery? The post surgery follow up counseling, how important are they?
Yeah, it's the crux of the management of endometriosis. Nowadays we don't have surprises like earlier, when the imaging or the pre-operative planning was not so perfect. When we used to go in with the operation, and the surgeons would be surprised, and they would be like they could stop because it was such a severe disease which they never anticipated. Nowadays we have very good pinpoint precise picking up of the endometriotic lesions, so we can really sit across the table and discuss the problem with the patient. Now the patient is aware of what problems can arise after, during the surgery or post-operatively. So she can take an informed choice, like whether she wants to go ahead with that surgery, or what is the exactly her nature of work, or whether she can right now go ahead with the surgery, or she has some exams coming up, or career wise, or she has to travel. So she can take a well informed decision about her surgery. Secondly, she should not wake up and find that she was told there is a simple surgery, and next time she finds a big stoma on the abdomen, and now for 3 or 4 months she just has to be live with that, and it's a big trauma and shock to her. So this should not happen in today's era now. Secondly, most importantly is there has to be a realistic expectation for the patient as well, because a lot of times the patient can have other problems, adenomyosis or chronicity of the disease, and the pain would still persist, and then she's unhappy with the treatment. So we really have to discuss all this, and this comes in the perfect diagnosis and a good counseling and a good relation between the patient and her doctor or the endometriosis surgeon. So definitely counseling is the key, and that's why I call it the crux for a patient to understand and take a decision about her excision surgeries. And there are, like, if this is not well informed or taken into account, that's the reason why we have so many patients undergoing so many surgeries for a simple diagnosis which was missed in the initial setup. Now, post-operative follow-up, we have to be very, very precise in understanding that this disease has some recurrence rate, So this recurrence could be in the form that the patient gets her pain back or her ovarian cysts back, or there could be the compression or the muscle mass is lost. So all these recurrences can happen. Now, if you just to give you an example, if the patient, which is the commonest, like 30% of our patients are ovarian endometriomas. Now, if you treat ovarian endometrioma, the chance of this coming back in 2 years is 29% if she is not on any medication. But if you counsel her properly and take it from her that she is going to follow up with you and she is going to take the post-operative medications, this 29-30% recurrence can be brought down to 8% just by putting her on any contraceptive pill which suits her the lowest possible dose, and if it is in a continuous fashion. Here we have this tendency that the women expect to have regular menstrual cycles, and breaking the treatment in between just by putting her on a continuous reduce the recurrence rate. So post-op follow-up is a must, and it has to be in a well converse manner before the surgery, and whether it is feasible for her career or her education or everything, whatever she is undergoing.
Absolutely. I completely agree with you. Counseling is one of the most important thing when it comes to endometriosis, because it is a complex disorder, and a lot of times patients feel that the minute the surgery is done, the next day they'll wake up having no pain. Again, that is something which is not a reality. It takes, first of all, the recovery takes a lot of time. I mean, every person has a different recovery rate, and also a long-standing endometriosis, something which is a grade 4, which has stayed in your body for a long time, can take as much time to heal also. And also, central pain sensitization is again another thing which can leave you in pain even after entire endometriosis has been removed. So for that, so there are certain things which have to be told to the patient beforehand so that they don't have unrealistic expectations. And also something that can reduce the rate of recurrence, obviously. So, Dr. Sandesh, is there something that you want to specifically tell the endometriosis patients?
First is you do your own research. It's a very, very important thing. Secondly, it's proved now that the first, if at all you are going for any surgery, it has to be the first and the last surgery possibly, and it has to be the best surgery ever. Okay, so for that you have to find out who are these people who can really perform or who are regularly performing the endometriosis surgery. Now, I'm not trying to undermine the surgeons or people who want to come up into endometriosis, but we have to accept the fact that it all depends upon whether you are performing this on a daily basis and what are the number of surgeries you are performing in a year. And that really has shown that those people who do it on a regular and the severe forms, they do better than the other surgeons. So for a patient, she has to find out these doctors. then there has to be a very good radiologist who has to pick it up, or the doctors themselves are now the gynecologists or the endometriosis specialists are learning for themselves to read the MRIs or ultrasound, interpret it properly, to give the patient a good pathway, like you have to follow this path. So I would urge these patients is to research a bit more before you accept or sign for the consent for a surgery.
True. As earlier, it used to be said that don't read Google, otherwise it will be like a half-baked
Scary.
knowledge. But trust me, when it comes to endometriosis, uh, for a lot of patients like me, Google has helped. There are a lot of online communities, a lot of advocates, a lot of doctors who have been advocating about endometriosis. I think I've learned more from the online platforms than I've learned from the doctors here. I mean, I'm sorry to say that, but it is a fact. So, honestly speaking, what I feel is advocacy, as of now, what I feel in our country at least, advocacy is done by a few patients because a lot of patients don't want to talk about it. A few patients and a few excision specialists. Because obviously, I say a few excision specialists because there are actually a very few of them who perform these surgeries. What I've seen is a regular OBGYN, they do not do advocacy for endometriosis because probably they don't do these surgeries. So I would request anyone, if you are not doing a surgery, please refer the patient to somebody who does it for improving the quality of life of that person. It is very, very important. It's
True.
important that we as a community works towards it, the doctors and the patients and the general population together.
True.
That will help. So um, so now, Dr. Sandesh, you practice in Solapur and Abu Dhabi. So tell us about your facility in UAE and what made you move to UAE in the
Yeah.
first place.
Uh, I was working in UAE for a long time, and what I could understand was the lack of centralization, or like the referral system, what you just quoted here. So I am working in Sholapur as well. I have my own setup here. So it's a pretty busy setup with a lot of endoscopy and endometriosis surgeries. But still, this thrill to work in a very, very dedicated multidisciplinary team was not happening for me, because here, we have individual practices. Like a gynec will have his own hospital, the bowel surgeon, gastroenterologist will have his own hospital, and everybody is pretty busy in their own setup. So coming for a patient might have multi-organ involvement, and to bring this team together for this particular patient was a bit challenging. Now over last 4 5 years, people have really understood, and we have developed our own team. But again, the other thing which was lacking for me was research. For me, the training part which I could have done, and so now I wanted to move from the, like, I performing all the surgeries. I wanted to move only performing endometriosis surgeries, and that has been my target for the last year. So to go into dedicated endometriosis, multidisciplinary, high volume, and very high advanced surgeries, I wanted a setup which I could envision and I could see it happening in Abu Dhabi. Now, fortunately for me, the hospital where I work in Abu Dhabi, the owner is a radiologist, and he really understood my problem. Okay, so because he could actually vision what I'm trying to tell him is that we need a dedicated multidisciplinary team, and so he immediately asked me, like, it's up to you to join hands with whoever you want, and we start that. Now a lot of these surgeries are, we are picking up so difficult surgeries. I need a robo for all these 50% of these patients. Now that it was impossible for me to do it in Sholapur. So again, that made me actually move from this place for partly to Abu Dhabi. So my hospital is really providing me everything that is required to bring up a center for endometriosis, and that they vision that it should be a referral system for a lot of countries, because Dubai or Abu Dhabi is again a very easy destination, and we can really have patients going to US or to Europe. We can really offer them the same facility earlier at UAE. So I am very lucky that now we have tied up with the center in France, which is the highest volume center or the best research work happening or the maximum publications. So Horace and Benjamin, they are the people who have joined us from Europe. And we have other multidisciplinary doctors with me in Burj Al Hospital here. And we have a group of 16 hospitals. So here we have established a proper, like which hospital can perform what surgeries. So the early part of the endometriosis can be handled in all the setups in our group. Then, depending on whether the patient has infertility, we have dedicated fertility experts who deal with the endometriosis patients, especially. So that facility is available for me. We have the best of the physiotherapy or the sports medicine team who are ready to offer the post-operative physiotherapy care for my patients. Dietitians are there. So whatever is required, we are able to offer them in that center. And when it comes to the sacral root endometriosis or the low rectum endometriosis, where the complications are very, very high, or diaphragm endometriosis, where you need a robo. So in all these facilities, everything is being offered to me, and they just believe in whatever I'm trying to tell them. So that made me move to Abu Dhabi, and that's why we have established this dedicated center for endometriosis in Abu Dhabi.
That's so lovely. That's so lovely to hear something like that happening there. I mean, I'm sure so many patients must be getting relief from this terrible condition. As much as I say that surgery is the key, I keep propagating that. But saying that, many people find getting an excision surgery very expensive. So, is there something you want to tell our viewers about?
Yeah, I really agree, and I feel very sorry because these surgeries are very expensive, because it involves a lot of doctors, it involves a lot of gadgets. Basically, the whole reason why I have not totally shifted or 100% why I prefer to travel and come back to my place is because I can really offer that to our patients here. You know, these are here in tier 3 cities. The hospital belongs directly to the doctor, and we can take our own decisions. So especially when the patient here cannot afford, we have our friends are there who support us with the equipments, instruments. So the patient just does not know where the equipments have come from or who's sponsoring for their drugs or their stay. So here we just tell them that there is going to be a camp happening for you, and we have sponsors, and we just perform those surgeries free. If advocates like you really find these like that somebody is really suffering and is just suffering because she cannot afford, you just send them to Sholapur. And I agree that we have friends who perform. I have Dr. Vimi, we have a lot of other friends all over India. Yes, who are ready to come and work free for these patients, because yes, this has to be available for each and every endometriosis patient. So absolutely, it's possible for us because it's my own decision and it's my own hospital. I can do whatever I want here.
No, trust me, doctor, having somebody like you or Vimmi or Dr. Hemant for that matter, I mean, it's a blessing for patients like us. And Vimmi, though, I would especially say, because she's like a childhood friend. So I think we go way beyond anything. So she's more of a family than anything else. And she's one of the best of the surgeons that India has, for sure.
It's a community for the endometriosis excision surgeons, and we know each one of knows the other person who performs endometriosis in India.
Absolutely.
So we really meet a lot of times, and everybody, believe me, they too have some limitations. We cannot offer this completely free because the hospitals they have their own costs involved. Okay. So, but when it comes to conducting one, 2 or 3 camps a year, we can do that and really offer it. And then everybody of us just comes together and offers our services, and we can really help. So,
That's
especially advocates,
just
because the
beautiful.
people approach you, you can really send these patients to us, and we'll do it for them.
That that would be really helpful for a lot of patients. Lot of patients, I'm sure. So, as a community, as a community, what do you think that should be done to improve the quality of life for patients with endometriosis?
This again is a big thing that has to happen actually, because these patients, they find themselves very lonely. They are not even getting support from their family members, and that's because we actually try to like keep them quiet, like ask them to keep quiet even if it's like the menstrual pain. So this understanding awareness is very, very important. What I feel is, and what I have tried to practice here in my place, is that it is time for us to go to schools, and teach every girl and boy there that there is some disease like endometriosis. This has to be through the schools, and everybody should be aware of endometriosis. That's the first thing that should happen, that there is some disease called endometriosis and it presents this way, and currently the whole world is struggling to diagnose it. Takes so many years, 7 to 10 years to diagnose, and then still more years to get treated. So it is time for us to teach these kids, and they'll go back and tell to their parents, then they will not listen to the parents asking them to just keep quiet and bear that pain and continue with that symptoms and not diagnose. So that is one thing. Then we have to train their parents. Then we have to train people like for the reproductive age group or people in career, for the other ones to understand that yes, she is not faking, the pain is real and she's really suffering, and she's not asking you for anything, she's just asking you to understand her. So then it has to come into their career and their workplace, and then of course the education also, and we have a lot of conferences happening. So this endometriosis awareness has to go across, and we have to just give a feeling to this individual who is fighting alone, that we all are together, and we can really defeat this disease.
Right, that's absolutely right. So the main thing is normalization of pain has to end.
True.
It is not normal to have pain which is so severe that you cannot get out of the bed.
True.
You know, so there has to be a distinction between a normal period pain and something which is not normal.
Correct.
So it starts from the school. I think this is something which we should do. We should start creating awareness campaigns in schools so that people are aware of the condition called as endometriosis. So I think we should work on this, and let's see how we can do this. I mean, that's something, this is one thing that I really want to do, Dr. Sandesh, and probably we'll do it. So
no, this difference I found when I'm actually for past 5-7 years, I'm going to France every 3 months to these centers. And there I found that people are aware of this disease. Now, if you see in Denmark, they have the best model of endometriosis treatment, where the country decides whether they are staying on the east side or west side to go to either Aarhus or to Copenhagen. So you have dedicated tertiary referral centers. Everybody is aware of the disease. So there then you don't find these mishaps or any repeated surgery, or actually the incidence of number of surgeries happening. This is very, very reduced. And now a lot of countries are bringing it in their parliament or their bills about endometriosis bills. So that will take time in India, but meanwhile we can educate our kids and then it would be easier. So not the elders, but we should start from the kids now.
Absolutely, absolutely. So that's like a brilliant idea. And is there a lack of understanding just in the society, or is it there in the medical fraternity also?
Yeah, unfortunately, yes, there is a lack of understanding amongst our doctors also, because there are a lot of myths in this disease. There is a lot of overlapping happening in this disease. And so a lot of times doctors also try to shut off there, like the patients are not listened to, or we are not we are trying to, a lot of these patients are put on treatment, thinking that it's not real and what she is telling is not true. So definitely there has to be a good understanding amongst the doctors. Secondly, this disease being multifactorial also, we have to understand that this has to be taught across the pathies, not only the gynecologists, but this disease or the awareness has to go to the orthopedicians, gastrointestinal neurologist, proctologist, or the renal disease doctors. So I feel there is a big gap in the dissemination of knowledge amongst doctors for this disease, and that has to end. True.
So as a curriculum, I think endometriosis has to be added as a specialty.
Yes.
That is something that's going to make a difference.
True.
That's what I feel. So, Dr. Sandesh, it has been like a brilliant session. Are there any parting words that you want to tell our audience?
First, congratulations and appreciations to you for conducting the regular programs which are happening, and a lot of awareness happening from you and good work. So I really appreciate you for that.
Thank you so much.
For the audience, I would say is now actually what I said is to create awareness, and fortunately we are discussing this in the month of March, which is actually being celebrated all over the world as the Endometriosis Awareness Month. So we should start educating whoever is there who comes across with these symptoms. Why don't you just ask her to check for if she is suffering from endometriosis? And most important, true.
Dr. Sandesh, 1 second. If somebody wants to ask a question, you can put in the comments. I will surely ask the question.
Yes.
Yes, Dr. Sandesh, please.
Yeah, and for patients, I would say is that just try to find these support groups. They are very, very important for you to be in an endometriosis support group, where you have like people of your same disease, where you can discuss with them. And there are some who are ahead of you in their management, treatment, so you can just take guidance from them. So this is very important. And very soon, believe that everybody would be understanding what is endometriosis, and there would be a big society to support these patients. So this is what I envision, and I feel that it's in a very near future.
Absolutely. Dr. Sandesh, there's a question that has come up. How do you treat diffused adenomyosis? Will your excision surgery remove all the diffused adeno from the uterus, or a uterus and cervix removal is a better option?
See, adenomyosis is a disease where the endometrium will go into the myometrium, and then it remains active there. So it bleeds inside the myometrium, that is the wall of the uterus. So from the cavity of the uterus, it goes into the wall of the uterus. It bleeds there and it is trapped. So it produces severe pain. There is no place or way for it to get out from there. And because of this, it starts hyperplasia, that is the cells around the blood cells. They start to grow in their size and they become big. So there is overall growth, or the size of the uterus increases. Now, if it happens only in one wall, like if you are in a room and only right side wall is involved, then it produces something called as a focal adenomyosis. But if this blood, it starts entering in all the walls and it grows in every part of the uterus, then it is called as a generalized adenomyosis. Now, if you have focal adenomyosis, I would say you are still lucky, because we can perform excision surgeries and we can really very well cover it with the overlapping, what we call is the triple flap overlapping method of suturing, where you can really strengthen it back and the patient can still have pregnancies. So when it is generalized adenomyosis, there were a lot of centers performing the surgeries for the generalized adenomyosis. But unfortunately, there were 23 uterine ruptures. In the review which was conducted, there were 23 uterine ruptures. and that really disheartened a lot of surgeons, and a lot of centers stopped performing surgeries on diffused adenomyosis. So what we do here is, but what can the patient do if nobody is going to perform these surgeries? Somebody has to do it, because they are really suffering from this disease. Now in India, if you ask her to remove her uterus and not having kids, then it's a big problem, depending on the social aspects also. So we really have to treat them. So what we are doing for generalized adenomyosis is we are treating them with in medication first, and trying to see if it can relieve her pain or shrink her disease and bring back the uterus by maybe 30%, 50%, and then depending upon if surgery is feasible. And if at all the surgery, if it does not happen, then we are going ahead with performing what is called as the Osada's procedure, where we perform like a H-shaped incision, and the uterus, the wall is opened. You remove the adenomyoma tissue, and then with the overlapping stitches, we suture them and strengthen the uterus. And now very recently we had what is called as the mesh plasty, which is not there in literature still, and it is just one rare case where the patient has continued to term and delivered just yesterday. So this mesh plasty, we are thinking of Dr. Hafiz and the team here, we are thinking of actually conducting a multi-center study to offer these type of surgeries, because something has to be done for these patients, and you just cannot ask them that nothing, we cannot help you anymore or remove uterus. So when you have completed the family, in that case we can offer you removal of the hysterectomy, or if you still want to preserve the uterus, partly we can do what is called as endomyometrectomy, where you come out with the most of the myometrium and the endometrium and preserve the uterus for psychological benefits. But otherwise, at present, people are offering them hysterectomy.
True, true, that's right. So I hope you got the answer. It was a very explanatory answer in itself. Uh, it was it was a session which I wanted to do for a very long time, and somehow it didn't happen. And but I'm so glad that we could do this today, and it would help a lot of people. I'm sure this is something which has brought light on a lot of aspects about endometriosis. So, Dr. Sandesh, thank you so much for joining me in this session, and I look forward to doing another session with you very soon,
Thank
sometime.
you. And I would invite you to Solapur, where we have tried a very innovative way now. I have explained this disease for the first time to my friend, and he's a sketch artist. And when I've told him about this disease, he has prepared now some 20 sketches and pictures for me about explaining this disease. So my our theme is to invite students, because a lot of times people don't want to come and listen to some medical topic, but when it is combined with art, so maybe they want to see some paintings and then understand, and that's a dedicated 100% purely endometriosis art show, where we would give them some information, awareness of endo. And I want you to be one of the chief guests for our
Oh,
session here.
I'm
So
honored. I'm absolutely honored for this, and I would love to be there. I would love to come to your facility and see
sure.
the art that you have got done.
Yeah, so
And
we
there
are
are
going to ask
there,
all students,
Dr.
every
Sandesh,
school
do
to
you
come.
have time to take a couple of more questions?
Yeah, it's okay for me.
Perfect. So, just one second. Yeah. So, post uterus and cervix removal, will the body produce much less estrogen even if the ovaries are retained? The doctor told me that the body produces high levels of estrogen during periods, so there won't be any problem.
No. Post hysterectomy, will the ovaries produce estrogen?
Oh, so, post uterus and cervix removal, will the body produce less estrogen? Is what she's asking. I don't think so. Ovaries are still there, right?
The ovaries, if the ovary is still there, then that, yes, definitely it can function and produce estrogen, which is required for the bones and the skin and the heart protection. So everything can be taken care. Even if the ovaries are removed, you will still have estrogen production. This is called as the mechanism is called as the peripheral conversion, where the fat will convert the estrogen, So estrogen production is not completely stopped even if you remove the ovaries. So this myth that endo will go away if you do a hysterectomy and remove ovaries, it's not correct. So the patient can still have estrogen production even if you have removed her ovaries.
Perfect. Thank you so much. Thank you so much, Dr. Sandesh. Dr. Sandesh, when are you planning to open up your the inauguration for your facility there for the paintings?
This would happen in April because right now these two schools are having actually exams are happening right now. So we don't want to disturb these kids. So as soon as after May exams are over, April we are going to invite all the schools to come and visit. It will be for 5 days. So we will be there to explain these kids
Amazing.
about this.
It's going to be a different experience, I'm sure, altogether. It's depicting endometriosis through paintings is something which I look forward to. It's going to be like nice.
I'll keep one painting as my status or today, and whoever is just listening to us can come and see what we are there to offer and those paintings.
Amazing.
And none of the painting will have depressing effects. All will have a positive message to take from that each painting. So he has ensured that.
Amazing.
Yeah.
Thanks a lot, Dr. Sandesh, and wish you all the best for further surgeries. And I will see you soon in another session.
Yeah, thank you so much.
Bye-bye.
Thank you.
Yeah. Take care. Bye. Bye. Thanks to all the audience for joining us and supporting us as always. Thank you for being there. Thank you. Bye-bye,
Thank you so
and
much.
have a good evening ahead. All right, done with the session today, and it was a brilliant session. I couldn't have asked for a better session today. And see you all again with another session soon. Wendy, WhatsApp me the questions. I will get back with the answer. Yeah? See you. Bye-bye.